Welcome back to the podcast, Can Silicon Valley Solve Healthcare? The podcast where healthcare leaders talk about technology leaders talk about healthcare, investors talk about impact, patients have a voice, and everyone has an opinion. Hello, and welcome to another episode of Can Silicon Valley Solve Healthcare? Hello, everyone. I am your host, Adam Silverman. I am the Chief Medical Officer at Syllable. And this week on the podcast, I am thrilled to have Eric Thrailkill with us live from Nashville. Eric has a long history in the technology and healthcare space. He's been the Chief Information Officer of a number of organizations, which he'll introduce to you. He's also been an advisor to technology companies. He's been a mentor to many, and he's been a very good friend of mine. So, Eric, welcome to the podcast.
Adam, thanks a lot. You do great work with your Can Silicon Valley Save Healthcare, and I'm excited to be here.
Well, tell our audience a little bit about yourself and a little bit about the work that you've done and that you're currently doing.
Okay, I'll start off with I originally hail from Florida, so grew up just outside of Tampa. I went to University of Florida and studied accounting. So I'm a CPA by background, joined one of the, at the time, big 8 firms that merged.
Now it's down to big 1.5 or, something like that.
I think maybe 4. It's about cut in half. But it was actually Deloitte, the firm that got me to Nashville from Jacksonville, Florida, back in 1983. Being in Nashville, you have generally a couple of career paths, and that's music or healthcare. The city has brilliant ecosystems in both. Healthcare was for me, so I got involved straight away with my background at Deloitte, and then joined 3 different companies, all as CIO at one time. They were all public companies at one point of their history, and they all had they were all on the provider side of the stakeholder equation, but they all had operations throughout the United States. And really quickly, those were a company called Ficor, physician practice, large multi-specialty medical groups throughout the country. Second company was a company that's now known as Horizon Healthcare, but was known as America Service Group, leading provider of health services for inmates in prisons and jails. And then most recently, 13 plus years with a company that was founded in Nashville, a pioneer in the ambulatory surgery center space, a company called Amsurg that went through a series of transactions and eventually merged with Envision Healthcare.
Excellent.
I left all of that in 2020 and now doing some interesting things, which I can dive in a little bit about.
Awesome. And we will definitely get into that because I find some of that work to be incredibly inspiring. But you and I have had a number of conversations around digital health and startups in the healthcare space and the interaction between them and their potential partner, client, or customer, whatever term you'd like to use for them, and the difficulty and the hard sell that exists within healthcare today. How do we get technologies, novel technologies, deployed in the healthcare setting? Why do so many startups, tend to find that a difficult process? So where I thought we'd start with this is maybe thinking about the evolution of the role of the CIO. As you started out, you were a CPA, and then you ended up in a role as a CIO. I don't know how many current crop of chief information officers, actually have an accounting background. But if you could hearken back to your days at Amsurg, can you talk a little bit about, sort of what your roles as the CIO was in those days, and sort of delve into what were some of your problems that you were tackling, what were your biggest expenses and purchases, really to sort of set the timeline, if you will, and anchor it at that period of time when you were at Amsurg.
I'm maybe a little in the minority with career backgrounds before advancing into the role of a healthcare CIO. I always thought my background was a little bit of an advantage in that I had the opportunity to participate at the strategic level of capital and operating expenses and budgeting, which every CIO obviously does, but got to view that from the lens of my role with Deloitte and previous companies of what really drove company strategy and the interplay with technology and information systems. So when I joined Amsurg, it was 2007. So if you think back to that point in time, early days of the financial crisis, a full 2 years before the High-Tech Act that was a part of the stimulus bill, and 3 years before the Affordable Care Act. So this notion of electronic health records and federal support had not occurred yet. A sidetrack was that ambulatory surgery centers were left out of that equation when that did occur 3 years past that point in time. There was a little distress in the company's business as a result of the financial crisis that hit in 2007 and 2008. And I was really hired as the first CIO in the company's history. So the company at that point in time was 15 years old. Our CEO used to like to think of a company's history in terms of a person. So think of a 15-year-old young man, young lady who's about to drive, who doesn't fully understand risk, who is not too far removed from middle school, and still relies on guidance like management and board of directors to make decisions. So it was an interesting analogy.
Yeah.
We did not have at that point in time a consolidated strategy for information systems. Each one of these surgery centers was a partnership. The partnership was with specialist physicians. The company's roots were in gastroenterology, so think endoscopy centers, and then followed by ophthalmology, and then later in life, about 2010, 2012, into multi-specialty ambulatory surgery centers. So small groups of physicians, individual partnerships. One's financial success did not impact the other's financial success, and no real strategy around systems that might enable us to represent quality and value as a consolidated entity. First thing we started to do was, and really the business challenge was, I had to sell internally a set of systems, revenue cycle and clinical systems, to individual partnerships that was the equivalent of a startup organization selling into healthcare.
Interesting.
The services, frankly, had to be better because they came from the company. The company and its operations teams were going out on a limb, per se, to recommend these solutions to participating partners. And they had to solve the challenges that existed for those physicians, doctors, and users at each one of those surgery centers. So frankly, it was why I took the job, that there was no history there. There was no baggage. There was a great future ahead. There still is, in my opinion, with ambulatory surgery centers. A lot of tailwinds kind of blowing in that direction. And it was an opportunity to work with a great team and build something that could really demonstrate value for those partnerships.
That's a fascinating. I never really thought about it that way in terms of how your role as an internal salesperson, an internal vendor, vendor of vendors
Exactly.
to these partnerships that you had. But I guess it's not a franchise model, but it's not too much different than a franchise model where you're trying to get the franchisees to all act in one way to support the brand, but yet they're all individual business owners in some way.
No, it's exactly right, because we thought that there were two key advantages, and this began to play out over time. One was, could you recognize some cost efficiencies with standard solutions that were operated generally the same way? Could you, in fact, build what's called a CBO, or a centralized billing office, that cost less than the individual, say, revenue cycle operations? The part that I was more interested in is, could the company begin to represent itself because of the quality and the safety of care that was being provided, with measures that would ultimately impact its contracting capability and its presence to grow in the marketplace. And that's what to me was exciting. We got the groups of physicians together frequently by specialty. They talked a lot about quality measures. They talked a lot about individual processes and safe, high quality, performance in an ambulatory setting, which is, if you remember the time, there was a lot of skepticism toward newly formed ASCs. Were they as safe as a procedure in a hospital? Were they as quality care could be provided when we branched out into specialties like orthopedics or urology and now cardiology? And the company I was with, was fortunate to be with a great company that had quality as a standard. So it was, I always viewed it as, wow, how could we obtain the data through the implementation of clinical systems and continue to provide education and resources through our clinical quality teams, and then demonstrate that quality to the purchasers of care, whether those were employers or government or individuals.
Right. So you were there for 13 years or so through the introduction of the Affordable Care Act. How did your role change over that period of time?
Yeah, it's a great question. I'd say the first, right before the ACA was the ARA bill that created the stimulus bill in 2009 that created the federal incentives for EHRs.
Right.
And as we sort of fast forward to where we are today, I was looking up some statistics. Very few hospitals at that point in time had electronic health records, and slightly more, maybe 16% of hospitals and slightly north of 20% of physicians had implemented electronic health records. And certainly, while there were standards by the ONC that was established in 2004, they weren't being used to what we now know as meaningful use in a way that would lend itself to standard and complete documentation. The challenge for us on the ASC side was that a lot of provider organizations, behavioral health units, ambulatory surgery centers, long-term acute care facilities were not included in those federal funds and therefore lacked the incentives to install electronic health records. You always could, but you had to build a business case that showed that investment in electronic health records was ultimately, resulted in value for the company, which, as you know, based on the way that a lot of services are paid for, sometimes it's not,
Right.
An advantage.
Right.
So if you're in a unit-based, fee-for-service-based unit, then, perhaps clinical documentation that really reflects evidence of quality and safety is not as valuable as it could be. Now that began to change, and that's what I loved about being with the company and the job is now you're on the forefront of implementing clinical systems without the benefit of the federal incentives and designed to reflect the quality of care that was being provided. The Affordable Care Act, I think, was interesting for us. The company's roots were in GI. So when I joined the company, maybe 150 surgery centers, and today that number is about 260 total. But most of those were single specialty endoscopy centers doing upper endoscopy procedures and colonoscopies. And the Affordable Care Act removed some of the barriers for colon cancer screening to certainly in Medicare population and commercial plans. And we saw an increase in the number of individuals that were then screened at that time, recommended task force at age 50. Now it's reduced to 45. And I want to say some of the data that we were actually able to collect was important for that change to be recently enacted. But I think that was beneficial for us because it removed a lot of the payment barriers associated with recommended colon cancer screening rates. And we've seen, and as you know, that colon cancer is a fierce disease that's impacted, I'm sure, many people that you know and many people that I know. You can have a good outcome if it's caught early enough. And it takes a high quality physician. It takes a well-informed patient, and it takes an organization that's delivering safe procedures for that to exist. And certainly it still is the gold standard for colon cancer screening today. So I would say the ACA was a positive impact on the methods that informed individuals in certain plans around colon cancer screening.
So let's fast forward to today. You and I had the pleasure of being in Nashville for Vive this year. which is a great event. Second year that I've been to Vive. Lots of enthusiasm from lots of people within the information technology vertical within health systems and elsewhere. How, as you walked around and you looked and interacted with the folks that were there, did you reflect back at all at how perhaps the position has changed over time and what today's CIO's responsibilities or what characteristics make up a good CIO today as compared to when you were in your heyday?
Yeah, I think a lot. I think that's a great question. And I would say in my day, it was simpler than it is today. The role of a CIO can take many different paths into strategy, and some organizations combine the CIO role. Other organizations have created a chief data officer role, and sometimes a strategy officer role, or a transformation role, or an innovation role. And some organizations combine one or more of those. And when that's done, the challenges for that individual are compounded, in my opinion, uniquely. I also think the threats that CIOs face today from a security and privacy standpoint are far worse. It's a shame that we have to spend industry dollars to protect against people with bad intent, but they're far more serious, they're far more sophisticated, and they continue to be. And that role of also ensuring security and privacy of key healthcare data that all of us believe, when used appropriately, can unlock new value for the entire system, is another challenge that today's CIOs, security officers, data officers have. I would say I knew early that the pace of innovation was far greater than a multi-billion-dollar company could do on their own. The pace at which change occurs in a big company is sluggish, is slow, is hard, takes a lot of consensus, takes unique relationships with vendor or solution providers, but also requires bringing on certain skill sets that might not have been present and heretofore in those large organizations. And one thing that I was intrigued with, which sort of gets me to my role today, is how does a big organization continue to provide high quality, financially successful services on a quarterly basis and keep one foot in the future with thinking about either new technology or new applications and services that could protect against other threats, but also could position the company for value down the road. And I would say it's incredibly difficult. We were experimenting with sort of a venture innovation unit at Amsurg. The company made a couple of investments in companies that it formed solution partnerships with. And we were all encouraged, and I feel strongly about this, to attend the very events, that you and I were at in March in Nashville. You can only learn so much by staying in your office, and it requires you to get out and see the facilities from day one that you're responsible for, but also to attend events where you can continue to learn and just be exposed to other strategies that peer organizations were undertaking. So I'm a big fan of innovation working this combination with those that are accelerating at a rapid pace and those that really know the organization. I'm not talking about myself, but those that work with a lot of executives who understand healthcare operations, quality and safety, security, and financial relationships at a very deep personal level. And those health systems that think they can do both, or provider organizations or payer organizations, I just think are challenged.
Agreed. It is such a complex role today, and it's easy to see how in some organizations, not that the role has been split, there seems to be still a quarterback at the top of the pyramid, but you do have, privacy and digital and telephony and security that all sort of, roll into it and inform it. You're right. It is unfortunate, the whole issue around security that health systems have to deal with. I think some health systems have tried to build a moat around their systems, which I don't think has worked particularly well, and has stifled, quite honestly, the adoption of new technologies. But I think it's interesting what's happened. You brought up the investment by the federal government in terms of the EHR. There's some estimates that $38 billion have been spent by the feds to drive EHR adoption. I'm curious, from your standpoint, what do you think of that particular investment? Has it had a return? Are we in a better place today than we were before the investment was made? And what did that investment do to your particular profession?
Yeah, wow, that's again a great question. I would say, to answer it, has it been a beneficial investment by the federal government? I would say unequivocally yes. We've seen, since just a little bit more than a decade ago. So we're into this, really since about 2012. So maybe just 11 years. The rules were formed 2009. A lot of infrastructure to support the early days of adoption were 2010 and 11. So let's call it a decade plus, or minus of widespread implementation of electronic health records. Now, close to 100% of hospitals and maybe above 90% of physician practices have installed EHRs. The beneficiaries of that digitized data is, I think, accrues in a number of different ways throughout the industry. I would say, though, that the journey is far from complete. And I think, as you know, it's sort of how long we live and the quality of life that we live is about 80% determined by some place other than where you receive your health care. And it's our own risk, our own behaviors. It's the true drivers of health, or what others might call the social determinants of health. It's our genetic makeup to a large point. And the table is set, I think, to bring in additional valuable data sets that could really accelerate the pace of medical innovation, the pace of diagnostics, the pace of treatments as a result of the industry's implementation of electronic health records. I'm hopeful. I would say it's frustrating for physicians and all of us that are close to the provider, the stakeholder group, understand that there is still tremendous burden with documentation and use of electronic health records as they were designed. But I'm hopeful that some of that can be improved with newer technology, or with sort of platform relationships that tie together various stakeholders a lot better than they do today.
I've called myself cynical, but you've tried to correct me and tell me that I'm just pragmatic. So if we think about, to put words in your mouth, the outcome from the adoption of electronic health records has been very positive. I guess my next question would be, was the method, how did the method impact healthcare going forward? So healthcare was not going to have widespread adoption with some commitment to standards without the federal government ponying up for the EHR. So has that had an impact on how healthcare views other types of technology? Did that create some malincentives or create some cognitive dissonance for people that now need to purchase technology at retail rates, let's say?
Yeah, I do think it has, and I think it comes through in a couple of different ways. I would say the success of a large scale system wide electronic health record is extremely difficult. It's difficult to tell the story. It's difficult to acquire and optimize those solutions. It's difficult in training and education. It's difficult to take very busy clinicians and then require certain training and education and assistance. It's difficult to overcome the objections for implementing electronic health records, and all of that difficulty sort of manifests itself in different ways. Budgets that are overblown, EHRs that need to be optimized several years into the future, burnout of both administrative IT resources and clinicians as a result, dissatisfaction and frankly, sort of a jaded opinion toward the benefits of technology in the industry, and none of that has been helpful with newer technology. I will say that the federal government, if you look at the government influence of where healthcare needs to be, I would say it's generally positive and generally bipartisan as a result. The 21st Century Cures Act, which was designed so that information could flow freely among provider organizations, and while was 7 years ago, written into legislation, and many of us feel is slow in its implementation and rulemaking, was a total bipartisan, vote of confidence. I want to say 92-8 in the Senate and 327 to 30 something lopsided in the House. The rules, the implementation, the law was President Obama and bridged administrations to the current administration. There's a lot of good work, I think, that's now happening with modern tools and technologies and FHIR APIs and identifiers that can be gathered. There's event notification services and repositories of data that now allow physicians and caregivers to have access to data that's outside of their just clinical documentation in the EHR. There's the intersection with social determinant data and genomic data that can again drive value to care providers and to workflow processes, et cetera. So I don't think we're anywhere near being maybe even halfway complete on this journey to really make use of the data that's captured electronically. And now we're on the forefront. I'd be interested in your reaction here. We're on the forefront of, maybe AI can have a positive influence, maybe this notion of ambient documentation or reducing, some of the barriers that are associated with actually using, a computer or a device during a clinical encounter could be overcome, where we can have richer data with less effort and still keep it secure and private and exchanged in a way that truly adds value to the enterprise system. And this is where I think, Adam, the work that's being done in this area, the truly innovative work, the cutting edge work with AI, and I'm not tossing out AI just to toss out a buzzword, but with predictive technologies or computer vision or generative AI, and there's many other types of AI, is that we're, again, really on the forefront of and haven't quite yet unlocked near the value that I believe we will over a period of time.
So I think that's very interesting because, one of the things that I've been sort of noodling around with is, I guess, more, again, the pragmatic opinion is that we wouldn't have gotten to the current glut of unstructured clinical data without the EHR, without widespread adoption of the EHR. We wouldn't have gotten widespread adoption of the EHR without $38 billion from the federal government. So why do we think that healthcare is ready to adopt these novel, newer tools that they're going to have to pay for out of their own pocket? I guess, that's sort of now I am trending towards the cynical side, but, I do think that there is something to, health systems. Healthcare is a really tough business. It's highly regulated. There's a lot of competition. It's a problematic business model. But having said that, there are many examples of technologies that are out there that could help make the delivery more efficient. And that's steering clear of clinical decision making. That's just saying on the administrative side of things, there are tools that are available, whether it's automation tools or analytic tools or consumer-facing tools that would make access easier, that I don't see like a stampede of health systems, showing up on the doorstep of companies that have these solutions and saying, yeah, we're ready to buy it. I actually think it's even harder today than it may have been 10 years ago. So, I'm a little skeptical, and I'm curious from your standpoint, even today, now 10 years into this treasure trove of unstructured data, I don't see a dominant player coming out either in the, on the side of the digital front door or analytics or on the automation side. And I'm curious what you think about that.
I think a lot about incentives too. And is it a mix of, do we have the incentives for the individuals? Do we have the incentives for the care providers, for the health systems aligned that the way they should be? When I've heard others, when asked the question, is healthcare broke? Many would say, no, it's optimized exactly the way it's designed, to be implemented. In fact, incumbent organizations are very, very good at it, of the way the current incentive models and the current payment models are implemented. But I look at, we still spend way too much of every dollar in administrative services, up to 25%, maybe even north of that as an industry. We spend, as you know, 2 times or 3 times as much as most other countries. Our health outcomes aren't any better, but there still is brilliant innovation that's occurring in a lot of different ways, and medical innovation and new treatment, new therapies, et cetera, that originate here, in this country. And if we were maybe to change the incentives, and frankly, if some of the newer players, I'm sort of looking curiosity at the big retailers that incumbent organizations totally dismissed a decade ago and said, what we know is a minute clinic or, a small little, nurse practitioner led doing sports physicals in a drugstore would never be a threat to traditional organizations. Now we're seeing, frankly, billions of capital in a lot of the non-traditional healthcare organizations, including the retailers and bigger tech companies, acquire significant numbers of physician assets and leveraging investments in technology to actually improve the consumer or patient experience, and moving sort of upstream in complexity of services providers is also a real threat to those sort of existing or incumbent health systems and organizations now. And will that drive some of the innovation or accelerate some of the ways in which tech can be used to either reduce cost or have an impact on safety and quality? I think so, but that's a sort of a macroeconomic, high level view.
So in addition to privacy issues, security issues, new and novel technology adoption and application, you're now throwing in competitors from outside the traditional landscape. So what advice do you have for the budding or the struggling CIO?
Oh, gosh. Talk to your peers. I've listened a lot lately and have full respect for those in the industry that really communicate and build their peer networks. And there's great organizations like Chime that are, putting really good conversations with, could be CIOs or chief digital officers, chief strategy officers, et cetera. And I think if you were to poll them and they would say, where do you go to get your sort of external information? And then how do you bring that in? A lot of them would say highly valued peer networks. I think what you're doing, frankly, with this podcast and others is allowing, a medium to exist where conversations like this can occur. I'm really high. We mentioned it earlier. Vive and Health, I think, have put together some good events that bring together non-traditional stakeholders in the industry, but also the existing organizations. And I would urge those individuals to be a part of it. I never felt in my career that I had any chance at all, and this is decades ago, to keep pace with contemporary innovation. You just don't have a chance. So you're either going to read a whole lot or trust a lot of people and try to get information. And I always found it valuable, those peer networks that can be established are good vehicles to do so. And I think any CIO would say, I used to estimate it was probably at least 80% of my time is you're spending talking to your own organization. You've got to go out and see. My first week at Amsurg, I was in Washington, D.C., visiting 6 different ambulatory surgery centers. I'd never really been in one. I'd been in a lot of other healthcare organizations or systems, but never been in an ASC. And I had to really understand the clinical processes, the patient from the position of the patient experience, talk to physicians and ask them about, their partnership and their procedures and what was important to them in then those facilities, and then speak frequently to all levels of management, whether that's finance or operations or marketing, around how they can better do their jobs and push the company forward as a result of IT.
I think that's so important. In my career, I saw a mixture of leaders, some that you could find routinely in their office, and others that were never in their office. And I think getting out and understanding what's going on at the front lines, particularly in healthcare, is just so important. And maintaining connection with the point of care, because that's really, when you're a leader in healthcare, all your job is to facilitate the delivery of high quality, empathic care at the bedside or the clinic side or the surgery center side, wherever the venue is. The rest of it, should pretty much, with the right tools, take care of itself. And I think it's the real mark of a leader to be able to get out there and be willing to be vulnerable, because you never know what's going to happen when you go out there. You never know who's going to come up to you with a question and challenge you. And I think it's really important for them to see us, not necessarily struggle, but, we recognize their struggles. That's why we're here.
No, that's true. And you brought up vulnerability, and I'll maybe chat about a little bit of the role that I've got today in leading Project Healthcare, which is
that was going to be my next question. So let's pivot and talk about Project Healthcare.
Yeah. So I'm excited about this. It's something that I started with in March of 2021, and had always known the Nashville Entrepreneur Center and knew of its various programs. I would say I was always intrigued with the idea of being an entrepreneur and thinking about, what I had frankly never done. I had essentially had 4 jobs in 40 years. So this role of entrepreneur and really being at risk, for building a company, was interesting to me. And I admired the people that did it, the risks that they took, and the passion for what they truly felt about, could bring about change through their companies, and thought that would be fun to be a part of, and in some small way to help them have a greater chance of success. So that's what we're doing at Project Healthcare. We're based in Nashville. At its core, we have an accelerator program, but we're larger than that. We do some key events. We've got a great one coming up on September 21st called the Telehealth Academy. We've got fantastic speakers addressing AI and generative AI and telehealth, virtual nursing from leading health systems, care at home models, including Best Buy Health, who's got an interesting hospital at home model that we're going to be speaking about. And it's just a good place to be, whether you're an entrepreneur or a seasoned executive of a health system, to continue to learn more.
How do you craft a positive, upbeat ecosystem for these folks? Because the reality of the world, and I think about my daughter who's in medical school. When you're in medical school, we bring you in, you're very enthusiastic, you're very committed to to wanting to help mankind. That's why you went to medical school. And then we throw you into your residency where we sort of beat the humanity out of you. And that becomes the reality going forward. So how do you, either you individually or you through Project Healthcare, how do you maintain this ethos or this ecosystem so that these entrepreneurs continue to be entrepreneurial and continue to, fight the good fight and not, run for the hills?
Yeah, it's. I think there's a lot of different degrees of support, and this is what I really view as my role and those that are running the program. So first of all, we have a curriculum, and our curriculum is about 75% of the sessions is done with outside speakers and guests who give up their time, who are experts in a particular area and are willing to share that with that group of individuals. We have, like many accelerators, we have a pretty impressive group of mentors and advisors. And these generally come in two flavors. They're those who have been on the entrepreneurial journey path, and they've known what it takes to perhaps fail maybe several times. They know what it takes in terms of the commitment, that not only the hours, but the emotional commitment that it takes to support a program. And they're highly important and influential to the accelerator group. And then the others are industry experts. And this is where I think healthcare is particularly challenging. It's my own observation after being in the program for a couple of years that the tech or the device or the solution generally works. And I sort of put that in air quotes. What doesn't work and what sometimes is really difficult is the business model. Well, who buys it? Why would they buy it? Who do you have to convince at that organization who's going to buy it that it's a good investment to make? And what will that be based on? And so how can you take a solution that does add value to some element within the industry, but figure out it's really got to have a health economics and outcomes research analyst or expert to help that organization build a business plan that ensures that the company can stay active and well funded, but at the same time deliver value to others. And I would say, and you and I have talked about this, on the other side of the buy decision making process, it's just a tough time. It's a tough time for all the peers that I had in the industry that are still there, fighting the good fight, every day. Work is challenging. Margins are low, and capital available for investment is scarce. But there's a sense of, and I really do believe this, that where innovation and maybe digital health was a novelty, and I'll say maybe a decade ago, it was cool that we could do some stuff from the home, or that we could capture data from these remote devices. But it was never really financially interesting, wasn't really contributing, to the care processes that existed. And now I think a number of organizations, and there was a good piece in the New York Times on the 75th anniversary of the NHS that sort of highlighted this as well, is that now you've got these traditional systems that are looking at digital and looking at innovation as a solution to a real problem. I mean, there's not enough, workforce, wait times for primary care visits and GP visits abroad. Higher acuity services are being recognized in outpatient settings and in inpatient settings. And all these challenges are incredibly real today. And now could you look at innovation and partnership to actually knock down some of these challenges that do exist? And I think anytime you have an industry that spends about 25% of its annual spend as an industry on administrative or unnecessary care, you have a ton of opportunity to make a difference. And I might be naive in that, but it just feels like, if we were operating at a super efficient, well-oiled patient and consumer experience, information flowing freely and no problems with, being able to submit claims for reimbursement or to be paid, then I would feel differently. But that's not how we operate today.
No, and I've also started to wonder, I say, we've been in this digital health thing for 10 years or so. It may just be that we don't know what the time course is going to be. I kind of think after 10 years, we should be at a destination, but maybe we're only a quarter of the way there. Maybe we're only halfway there. Maybe we just need to keep pushing. And, this tension needs to exist to make sure that we are developing the right solutions, the best solutions, the most effective and efficient solutions. Because, to your point about the NHS, writ large in any industry through this country, our population isn't growing. And so if the economy is going to continue to grow, we need to be more efficient. And right now, the only way I know of for many of us to be more efficient is to give us tools, and those tools are going to be generative AI or some, large language model built types of tools. Just like, you could get rid of my secretary by giving me, the Microsoft Office suite. Now I can do those things on my own and I become more efficient. So it's an interesting time for us. I appreciate you bringing me back from cynicism to pragmatism, and I'm working on my way to be more optimistic like you. But this is why I love talking to you, and we've come to the end of our time together, and I do appreciate it. I know we could continue for hours more. So I think we will have to bring you back for another edition of Eric Thrailkill and Can Silicon Valley Solve Healthcare? But Eric, thank you so much for your time today. I really do appreciate it. And we'll look forward to having you back soon.
Well, and thank you. And cynical is, your voice needs to be heard. I mean, there are challenges at every level, and those need to be, stated fairly and accurately. But who you are as a person, you're always listening. You're curious like I am. You're always learning, and at the core of it, you're a contributor to the industry. So thanks for doing that. And I do think you're right. I do think we're in this for a long time. I tell my son, who's starting his career in healthcare, you got a job for 50 years, because it's going to take a long time to solve this thing that we know as U.S. healthcare. So buckle up. It's going to be a good ride, and you'll enjoy it and make a difference.
Very true. Thank you so much, Eric.